Hi, I'm Emily Barsky. I'm one of the pulmonary attendings at Boston Children's, and today I'm going to provide an introduction to the management of CF exacerbations and CF emergencies, mainly on the inpatient side. So we're going to start by talking about CF exacerbations. You guys will encounter these very commonly when you're the inpatient fellow on the wards. Many times the admissions for CF exacerbations are scheduled ahead of time, electively or urgently, by the primary provider. Other times, the patients will come through the clinic and be directly admitted to the floor. They might present to the emergency room or be admitted from home emergently. If you can, it's useful to review the patient information ahead of time prior to the admission to determine a plan. So as much as you can, try to look up the scheduled admissions the day prior to their arrival to determine an antibiotic regimen. An admission schedule will be sent out by email each week, and it's usually updated on a daily basis. As well as you coming up with your own antibiotic regimen, if you have time, try to sit down with the interns and help them to do the same so that they can learn from the experience. It will be important in doing so to review allergies and to review cultures. The personal antibiogram can really help you with this. Someone on the floor can show you how to do this if you don't know where to find it, but when you go into the microbiology tab, you'll see all the cultures. You should try to scroll back and set your date range so that you're looking back at least 5 to 10 years, if not from before, so that you can see all of the organisms that the patient has grown. If you click on this little tab at the bottom that says Personal Antibiogram, it'll open up this window that's shown below. And this is a great way to sort by organisms and culture dates to look at sensitivities. Once you click on an organism, and what I recommend doing is, for example, in this case, taking all of the Pseudomonas colonies and selecting them with a checkbox, and then on the right, as you'll see, it'll open up the sensitivities. And whatever is highlighted in yellow will show you what the patient has been pan-sensitive to for that organism. As you can see here, ciprofloxacin this patient has been sensitive to, but the other things have had intermediate resistance or intermediate sensitivities. Any of the older fellows or attendings can probably show you how to use this if you're not able to find it in PowerChart. In addition to looking at the antibiotic cultures and the allergies, it's also important to review prior admissions and antibiotic regimens that the patient was on to come up with the best therapy. It's helpful to compare this to the PFT trend, so to look at what antibiotics the patient was on for the last several admissions and whether or not the PFTs improved and how much, and also clinic notes and discharge summaries can help you tell if there was a clinical improvement matching the PFT improvement, and also how long lasting it was. So if the patient was readmitted a couple of weeks early, you might want to think about a different antibiotic regimen. When you're choosing your antibiotics, try to cover the main organisms and those associated with rapid lung function decline, like MRSA and Pseudomonas. We try to double cover Pseudomonas with 2 different antibiotics, and if you can, try to avoid using 2 beta-lactams for this so that you have 2 antibiotics working through different mechanisms. You also want to not have more than 1 nephrotoxic medicine, if you can, and at most 2, to protect the kidneys, since AKI is relatively common. In general, we usually try for 2 IV agents and maybe 1 oral or 1 inhaled. Sometimes patients will just be on 1 IV agent, and sometimes they'll be on 3. Also think about the frequency of your dosing and the antibiotics you've chosen if the patient plans to go home on IV therapy. So a Q6 medicine would not be a good choice if the patient's going to go home to complete their regimen, because it'll be too challenging for the family to do. In addition, if the patient has a lot of allergies and requires desensitization for one of these, think ahead and talk with your attending so you can figure out if it should be a planned admission for desensitization or if you'll later transfer them to a different ward for the desensitization. Monitoring progress while the patient is in-house once you've started your antibiotics. So I generally recommend that if no PFTs were done for a week prior to the admission, you consider obtaining them on admission. And the reason for this is that sometimes a patient will have PFTs in the clinic even a month before the admission, and the admission was scheduled for a month later. During that period of time, you don't know if the PFTs have stabilized or even worsened further. And so if you just obtain PFTs 1 week into therapy, it could potentially be the same as it was over a month before, but you don't know if that means your regimen had no effect or if the patient's PFTs were further down and then started to come back up. In addition to PFTs on admission or shortly prior to admission, you should get weekly PFTs to gauge improvement, and if there isn't significant improvement on spirometry or clinically, think about changing your antibiotic regimen. For patients with severe lung disease, once the FEV1 falls below 30%, we often also obtain weekly 6-minute walk tests, and physical therapy does this because this is sometimes a more sensitive marker for improvement. Also, it's important to monitor the symptoms and the exam, and oftentimes you'll even notice patients' lung exams will improve over only a few days. What do you do if the patient is not improving clinically or spirometrically? The first thing to do is probably to alter your antibiotics. For patients with very resistant organisms, continuous beta-lactams can be one option. If they're really refractory to several different changes in antibiotics, you could think of some out-of-the-box agents like chloramphenicol, and think about whether or not the patient needs anaerobic coverage if you haven't been providing this already. This is also a good time to look at whether or not you're covering all the organisms. So again, review the micro. You might need to go back further and think about what you're missing. You might want to send a beta-D-glucan and a galactomannan and fungal sputum cultures as well to look for fungal disease. You might want to send AFB cultures, look back and see if they've ever had a history of mycobacterium. Review the patient's IgE that they usually had on admission, and if it was elevated, think about sending an ABPA panel if the clinical picture fits. You might want to do spirometry with albuterol to look for bronchodilator response, and if there is a response, the patient may benefit from a short course of steroids. You can evaluate for sinus disease, as often chronic sinusitis is a reason for lack of improvement. And you can also consider a chest CT as well as a flexible bronchoscopy. So that concludes the section on CF management. And again, that's really just an introduction. You will get really good at managing these after some of your time on the inpatient ward. I'm going to transition to talk about the CF emergencies to prepare you for some of the things that come up oftentimes at night and to also help your house staff with these emergencies. So we're going to start with a case. This is an 18-year-old with CF who has moderate lung disease. She's admitted for a CF pulmonary exacerbation, and she started on IV antibiotics and aggressive airway clearance. This is basically your typical CF exacerbation admission. We're now going to go through a couple of scenarios that might come up with this patient. So on hospital day 2, she might develop tachypnea and worsen shortness of breath. She could develop hemoptysis, or she could develop abdominal discomfort. And for each of these scenarios, we're going to talk through the differential diagnosis and the initial evaluation and management. So tachypnea and worsened shortness of breath. A short differential for respiratory distress in CF includes mucus plugging, which may in fact be the most common, infection or worsening infection, a pneumothorax, and a pulmonary embolism. It may be hard to see this on your computer screen, but this was a patient who was admitted and then developed shortness of breath. And if you look closely, you can see along the left side, there's a pneumothorax. So pneumothorax and cystic fibrosis has an annual incidence of about 0.6% and a lifetime prevalence of 3 to 4%. So it's actually relatively common. It usually occurs in older, sicker patients, so probably some of your teenagers or the young adult patients. The management of pneumothoraces. Should airway clearance be stopped? We often stop chest PT if it's a large pneumothorax. We might continue it if it's a small pneumothorax, but not always. Nebulizer treatments. We do often continue some of these, but not others. So as you can see, here are some consensus guidelines for withholding inhaled therapies for pneumothorax. And as you can see, there's some to good to very good evidence to actually stop all of these, including hypertonic saline, pulmozyme, bronchodilators, and inhaled antibiotics. I think in practice, we do often stop the chest physical therapy, the hypertonic saline, and the pulmozyme because these can make patients cough and increase their intrathoracic pressure, but we will often continue things like albuterol or inhaled antibiotics to treat the exacerbation. Should PFTs be avoided? Yes. PFTs, like some of the inhaled therapies, can greatly increase the intrathoracic pressure and could worsen the pneumothorax. And we generally wait at least 2 weeks after resolution of the pneumothorax to obtain PFTs. This can make things slightly challenging when you're managing someone for a CF exacerbation because you don't have PFTs to guide you in determining whether or not your antibiotic regimen is working. So you'll have to go much more based on symptoms and exam. When should a chest tube be placed? There are a couple of different guidelines you can use to determine whether or not to place a chest tube, but across the board, if there is tension, either by physiology or by imaging, the patient needs a chest tube. And the criteria for CF is slightly different from non-CF pneumothoraces, but for CF, we usually place a chest tube when there's a large pneumothorax. You can look at the American Thoracic Society criteria or the British Thoracic Society criteria. They're slightly different, but for example, the British Thoracic Society criteria suggests that a chest tube should be placed whenever the pneumothorax is large enough that it's 2 centimeters from the lung margin to the chest wall at the level of the hilum. Of note, once a chest tube is placed, oftentimes you can be a little bit more aggressive in your airway clearance regimen since there's already a pop-off. Is it okay to use BiPAP? As I mentioned, a lot of the patients who get pneumothoraces are older and sicker CF patients, so many of them are on BiPAP at night. But no, you should try to avoid this, particularly if the patient does not have a chest tube in, because like the other things we discussed, this can increase the intrathoracic pressure. When should pleurodesis be considered? This often comes up and is a big area of debate. In general, for CF patients, pleurodesis should be considered when there's a continued air leak, suggesting that the pneumothorax is not resolving. And there's really no criteria for how many JAs you wait for this, and a lot of the surgeons will differ in their clinical practice. The other reason to proceed with pleurodesis is if there is a recurrent large pneumothorax. This is slightly different from pneumothoraces in the non-CF population, which often suggests with any recurrence, even if it's small, you might consider pleurodesis. Will pleurodesis affect decisions around lung transplant? Because many of these patients are often older and sicker, they might have poor lung function, and in addition, some patients go to transplant simply because they have such recurrent pneumothoraces that they're debilitating. This again is always changing and often debated, but in general, it's not an absolute contraindication, but it does affect the ease of the surgery because it results in scar tissue, and so it's difficult to get the lungs out of the chest during the transplant. In general, we really try to avoid this if we can, especially if the patient is listed for transplant. And we definitely always avoid talc. So if you did have to proceed with pleurodesis, you'd want to do mechanical or doxycycline. Make sure before you think about this, you always touch base with the transplant team to have them weigh in on the situation. Okay, so that's everything for pneumothoraxes. We're next going to go on to talk about hemoptysis. The differential for hemoptysis in CF is quite broad, particularly if you don't know that it's definitely coming from the lower airways. But in general, they can have nosebleeds that mimic hemoptysis, and patients with CF are predisposed to this because they have nasal polyps, and their nares can also be dry from supplemental oxygen. If it's hemoptysis coming from the airway, which is obviously the most common, you get tracheobronchitis and bronchiectasis with resulting bronchial capillary engorgement or erosion. In addition, the sheer force of coughing can contribute to this. Parenchymal issues such as the infection can also contribute. Almost all CF patients that are pancreatic insufficient have vitamin K deficiency, and so while this by itself won't cause hemoptysis, it can contribute to it. In addition, if the patient has liver disease or dysfunction, this could also make the bleeding worse. And then similar to bleeding from the nose, GI bleeds can also mimic hemoptysis, and patients with CF might have peptic ulcer disease, or they could have esophageal varices. So once you've really determined that you think this is really from a lower respiratory source, I just wanted to talk a little bit about the physiology and the pathogenesis for what actually causes hemoptysis. So this can be either the bronchial capillaries or the bronchial arteries that are bleeding. As I mentioned, the bronchial capillaries get engorged and erode into the airways, and this is basically a process due to the ongoing inflammation and infection in the lungs. This is often more of a small bleed or streaking or small volume hemoptysis. In contrast, as CF disease progresses, the bronchial arteries or collaterals enlarge and they can rupture into the airways, and this is usually what causes massive hemoptysis and requires treatment with embolization. Hemoptysis in CF is quite common. About 10% of all patients will have hemoptysis at some point, but it's usually scant to moderate. However, 4% of patients, or approximately thereof, will have episodes of massive hemoptysis. In general, hemoptysis can be acute or chronic. So for acute hemoptysis, it's more common with an exacerbation. There are some patients who have chronic hemoptysis where they hemoptysize small amounts even on a daily basis, and they sometimes are managed medically with things such as propranolol. Evaluation of hemoptysis in CF. First, it's important to make an assessment. Oftentimes you may not be there, but encourage the residents to look at the specimen. When doing so, you want to quantify the exact volume. Patients often overestimate, as well as nurses and everyone else, how much volume of blood there is. So try to have it poured into a cup where you can measure the volume. You also want to take note of whether or not it's all blood or if it's mixed with mucus, and whether it's old blood, which is usually more brown, or fresh blood, which is bright red. Also inquire as to whether or not the patient has a history of embolization, and you should ask the patient if they can localize it to one side. Sometimes they can and sometimes they can't. In my experience, they sometimes describe it as a warm, bubbling sensation in their chest. The initial management. The first thing you want to do is put a pulse ox on the patient if they're having significant hemoptysis, and you can try supplemental oxygen as needed or for comfort. If the patient can localize the bleeding, you should put that side down. This has two main effects. The first is that it can tamponade the bleeding, and the second is that it prevents spillover into the other lung. However, if the patient is really uncertain, or if your exam doesn't match this, you might want to just leave them upright. Send. You should send off labs including a CBC, coags, and a type-in screen. What should you stop? Well, if it's more than 5 mLs of blood or more than streaking, you want to stop your airway clearance. This includes chest PT, hypertonic saline, and pulmozyme, which can all cause the patient to cough more. We often will continue inhaled steroids, albuterol, or inhaled antibiotics, although some evidence does exist to stop all of these therapies. These are the same consensus guidelines we looked at previously, and here they are for hemoptysis, which shows that there's some to good evidence to stop all of these therapies. But as I mentioned in practice, we often will stop the PT, the hypertonic, and the pulmozyme, but continue the other medications. You often want to give vitamin K. As I mentioned, almost all of these patients are vitamin K deficient. We often will give this even if the INR is normal. If it's just streaking or very small volume, you can give the vitamin K orally, which is 10 milligrams orally daily for 3 days. However, if there's significant bleeding, you want to give it sub-Q, and again, the same dose, 10 milligrams daily for 3 days. We really do not use IV, so make sure that the interns know that they should be ordering this sub-Q. Prothrombotic agents. We do sometimes use these, and I think these are used much more frequently in the young adult service, but these include tranexamic acid, Amicar, and less commonly DDAVP. Just remember that these will make the patient coagulopathic, and they should always be discussed with the attending prior to starting. So when should you call IR? Well, there's no firm line, but if the patient has had a history of embolization, you usually have a lower threshold, at least to let them know. Interventional radiology is not in-house at night or over the weekend, and so it will take some time for them to mobilize and come in if needed. If the patient's having small volume hemoptysis, such as 25 mLs or even 50, and it's just one or a couple of times, you usually don't need to call them. But if it's large volume, getting up towards 200 mLs, or it's happening repeatedly and adding up to that amount, you should notify IR, at least for the heads up. And usually it's better for the fellow to call than the interns. This reminds me that when a patient is having hemoptysis and it's recurring, you should have the nurses tallying up the total amount of blood and adding it to the specimen cup, because you really want to keep track. When should the patient go to the ICU? Oftentimes these episodes of hemoptysis, if it's more than just a little bit, make everyone nervous, the house staff, the nurses, the fellows, and everyone. But oftentimes these patients are stable on the floor. Obviously, if they're having massive hemoptysis, which is getting up towards 200 or 250 mLs, you might have to think about it, or if they're obviously unstable. Should you treat with antibiotics? Well, as I mentioned, hemoptysis often occurs in the setting of an exacerbation. And so generally, if it is more than about 5 mLs, we recommend antibiotics. Oftentimes, these patients are already in the hospital for an exacerbation, in which case it's a moot point because they'll already be on antibiotics. What about a bronchoscopy to localize? The data show that there is really no utility to this. Occasionally, IR will like us to bronch the patient to help localize at least to one side, but I think we're getting away from this more. And interestingly, the best predictor of location is not bronchoscopy or CT, it's the patient report. And I think this is because by the time you get to a bronch or a CT, there's often spillover into the other lung, and so it's hard to determine where the source is coming from. What are the indications for bronchial artery embolization? So there's no firm indication. I think you consider this when it's massive or persistent. I think when we're getting towards 250 mLs, which is about a cup of blood, oftentimes our team will push for this. This is basically what it looks like. So the patient will go to the IR suite and they'll see basically a flush, as you can see, a blood over here, and then they'll know what to coil. When is it okay to resume airway clearance? We often resume things one at a time, and usually after about 24 hours without hemoptysis. Again, this probably does not need to occur if the patient is just having streaking. And obviously, if it's a huge bleed, you might wait more than 24 hours. But for example, if the patient has one episode of 10 mLs and then nothing after that, after 24 hours, you're probably going to restart things in a stepwise fashion. You can really choose what you want to restart first and in what order, but generally if something has caused the patient to hemoptysize in the past, and they'll often tell you, oh, I think the hypertonic or the pulmozyme is what really irritates me, then you might do that last. So we often will start chest PT first and then NEBS the following day, one at a time, or each of those after a 12-hour interval. When is it okay to do PFTs? Well, there's no rule, but we often wait several days if it's just one time small volume, and sometimes a week, and obviously longer if the patient's been embolized. So that covers hemoptysis. And lastly, we're going to talk about abdominal discomfort and CF. What is the differential for abdominal pain in a patient with cystic fibrosis? There's quite a large differential, but I just wanted to mention some of them. Constipation is quite common. There's also distal intestinal obstruction syndrome, or DIOS, pancreatitis, which is more common in patients that are pancreatic sufficient, CF-related liver disease, infections such as C. diff. We often will forget about this, but just remember that these patients are on antibiotics, and a lot of them quite frequently. Recurrent intussusception can occur. They can get kidney stones, fibrosing colonopathy, which I'll talk about a bit later, appendicitis, and peptic ulcer disease. What's your initial management or evaluation? Well, there are a number of labs and studies that you can consider, and you'll obviously need to tailor it to the patient scenario, but you can consider a CBC with diff, a CRP, electrolytes, LFTs, certainly amylase and lipase if you think the patient's at risk for pancreatitis, a UA, stool cultures including C. diff studies, and then very often we'll get a KUB to help assess stool burden. And as I'll go into, this will help us to differentiate constipation from DIOS. Pending all of these things in the clinical picture, you could consider a CT, but I would say we do this pretty rarely. So here are a couple of x-rays, and this is DIOS, which is distal intestinal obstruction syndrome, and I'll talk through what it actually is. But as you can see, there is a classic bubbly granular appearance in the right lower quadrant over here, and then you'll see on the left side there's often a sky ball of stool. You can also get air fluid levels. This is what a CT scan would look like for distal intestinal obstruction syndrome. As you can see, there's dilated bowel with inspissated stool, and then the distal bowels are decompressed. So what is distal intestinal obstruction syndrome? It's actually pretty common in cystic fibrosis, and it can be somewhat of an emergency. About 15% of CF patients will get it in their lifetime, although the estimates range all the way from 10% to 47%. The pathophysiology involves thick inspissated secretions in the bowels, similar to in the airways. There's also decreased water. There's decreased pancreatic enzyme secretion and abnormal bowel transit, and all these together can make for the perfect storm. Risk factors include severe genotype, pancreatic insufficiency, dehydration, poorly controlled fat malabsorption, a history of meconium ileus, a prior history of diose, a history of organ transplantation, and CF-related diabetes. The symptoms actually can mimic appendicitis, and they include right lower quadrant pain, distension, emesis, and constipation, and they're often acute onset as opposed to constipation, which can often build up more gradually. You should obtain a KUB to evaluate for air fluid levels and stool burden, and as I mentioned, you'll often see this bubbly granular appearance in the ileocecal junction, and you may also see air fluid levels. Complications include bowel perforation and intussusception. So this is basically a bowel obstruction, but particular to CF. What is the definition? So you can have either partial or complete diose. So here are 3 things that are used, and if you have just number 2 and 3, that's considered partial or incomplete, and if you have all 3, that's considered complete obstruction. So the first, number 1, is complete intestinal obstruction as evidenced by bilious emesis or air fluid levels in the small intestine on the KUB. So again, that's only present in a complete obstruction. Number 2 is a fecal mass in the ileocecum, and this can be either on your KUB or other imaging or on your exam. And the third is abdominal pain and or distension. So how do we manage this? Well, for both partial and complete, you're going to do supportive care with bowel rest, IV fluids, antiemetics, and you need to consult GI. If it's partial, so if there are no peritoneal signs and you don't have air fluid levels and you don't have bilious emesis, you can start with a clean out, such as with Go Lightly, and if there's no response, then you would proceed to a gastrograph and enema. If there's complete diose, so again, air fluid levels, bilious emesis, peritoneal signs, you need to consult surgery, and you will have already consulted GI as well. You need to put an NG tube in for decompression, and it is not enough to just vent the patient's G tube, and you proceed to a gastrograph and enema. After this, you'd then do a clean out as you would do for partial DIOS. For the cleanouts, you guys will get quite used to these because we have a lot of patients that come in for constipation, but there's an order set. They usually need an NG or can go through their G-tube, since many of them have G-tubes, and you can run Go Lightly and you're going to ramp it up and you get up to about 300 to 600 mLs per hour, and we'll continue this clean out until the stool is clear. These patients often need many, many liters of Go Lightly because they have such severe constipation. If you're doing a full clean out, you want to make sure to add K to their IV fluids. Other options include Miralax, lactulose, and Mucomist enemas. And I think unlike in other settings, I really recommend that you repeat a KUB after you complete the clean out. Sometimes the stool will be clear and then the patient will get discharged and they'll come right back, and actually they still had a lot of stool left. So I just wanted to mention a few of the other causes of abdominal pain that I mentioned on the differential. The first is CF liver disease. Patients can get cholestasis, focal biliary fibrosis, and cirrhosis. Fibrosing colonopathy is something that's iatrogenically caused from high-dose pancreatic enzymes, and this is why we really calculate carefully and make sure we don't go over a maximum amount of enzymes, and you'll hear nutrition talking about this. Given that we're careful about this, we see this very rarely, but it does resemble DIOS. The patients will have constipation, vomiting, abdominal distension, and the imaging will resemble an inflammatory colitis. Renal stones are also associated with malabsorption, and so this leads to hyperoxaluria and hypercalciuria. And then lastly, interestingly, appendicitis has a lower occurrence in CF than in the general population, but it's always something to think about, especially since diose can also present with right lower quadrant pain. So this concludes the talk on management of CF exacerbations and CF emergencies. You should all receive the pulmonary pearls, which includes further information and assistance with antibiotic choices and management of some of these emergencies. Thanks for your time.